series in arthroscopy, and this week is we're starting on shoulder instability now. So first of all, I would like to welcome all our faculties. Two from talking about evidence. One is Dr. Akil Prabhakar, who is at Velamal Medical College in Vale Hospital and also in Vale Hospital. Who is going to talk on intervention in first-time shoulder dislocator. What the evidence is about. That's what he is going to tell about. Next is I welcome Dr. Jyoti Prasanth, who is a consultant in GM Care Hospital in Kannur in Calicut in Kerala, who is practicing shoulder arthroscopy there. He is going to talk on etiology of redislocation after arthroscopic Bankart repair. So, and for the expert talk, I have our guest speaker, who is Dr. Ali Maqdes. He's the consultant shoulder surgeon who is working in 3 hospitals in Kuwait, and is working for government sector as well as private sector also. Welcome, Dr. Ali Maqdes. Welcome to you. And he is going to tell about technique of surgical repair in shoulder instability. He is going to share his experience. So this is what our program is going to be today. And the program should last roughly for about an hour maximum. So 2 evidence talk will be for 10 minutes each. Then you have some time for discussion. And then experience talk is for about 15-20 minutes. I thank OrthoTV for channelizing this program in the OrthoTV channel. Thank you, OrthoTV team. And I also thank Sun Pharma team for helping us to organize this program. And I thank all the delegates and faculties for attending this and leaving this at any point of time. Thank you very much. So with this small intro, we will kick off with this program. And Dr. Akil Prabhakar. So maybe we can, Akil, are you ready for sharing your screen? Or what we can do is we can, Jyoti, if you are ready, can we start with yours? And then we can come back to Akil's.
Yes, we can, yeah, we can share the screen.
Okay. So we can start on with your presentation. Your talk is going to be on etiology of redislocation after arthroscopic Bankart repair. It's a really interesting topic. So let's see what the evidence says about recurrence after Bankart repair. After your talk, we'll come back to Dr. Prabhakar's talk.
Okay.
Are you ready to share the screen?
Yeah, yes, sir. Can you see me? The PowerPoint? Is the PowerPoint visible?
No, sir.
Okay.
Just to click on share screen, sir.
Yeah, yes. Just a minute. Yeah, now is it clear?
Yes, sir.
Yes, you can see.
Can you go to slideshow, sir?
Okay. So, good evening, everyone. It is really an immense pleasure that I am having today on discussing the redislocation possibilities after arthroscopic Bankart repair. It's a pure review of articles, as KNS sir has told me. So, first of all, I should thank Dr. KNS sir for the opportunity.
Jyoti?
Yeah.
Audio is not clear for some reason.
Now can you hear me?
Yeah, I can hear you now. Yeah, go ahead.
Okay, sir. So, thank you very much, KNS sir, for this opportunity and also the opportunity of sending me to UK in 2018. I was his fellow and I was fortunate enough to go to UK and visit Mr. Angus, our teacher in shoulder arthroscopy. So this talk is entirely article based and not at all experience based, because I was rather fortunate to have not much experiences in the redislocation of arthroscopic Bankart repair. So I will not confuse you with the p-value and the chi-squares. The evidence speaks, that's all. So shall go through only relevant conclusions. So the recurrence rate of an arthroscopic Bankart repair is 3 to 35%. That is what papers say. So the talk is basically how to get your recurrence rate as low as 3%, considering the evidence which is available today. So first of all, regarding the position in which we do the surgery, that is lateral position is told to have a lesser recurrence rate than V-chair position. So lateral position is said to have 8% only recurrence rate, and the V-chair position has 16.5% recurrence rate. So this is one of the papers in that. And the anchor position is also very important. The 5 o'clock anchor is very much detrimental in preventing the recurrence rate, says many papers. And most of the papers which I referred, that is risk factors for recurrent shoulder instability, the number of anchors always showed that is it should be more than 3. So any number of anchors which is less than 3, or some papers even say less than 4. So however less than 3 is almost detrimental for failure after arthroscopic Bankart. So the number of anchors is always more than 3. Then addressing the humeral defect by measuring the hill sacks. So that is another in which many papers have shown that the volume of the hill sack lesion is very important. That is, if you get a massive hill sack, that if you measure with an arthroscopic probe, the hill sack measuring more than 250 millimeter cube, that is the volume of the hill sack. 250 millimeter cube.
Sorry, sir, your slides are not moving. Kindly go to slideshow, sir.
Now can you see?
No, sir. Still it is on the first slide only.
I'm doing the slideshow only. Can you see it?
No, it's not.
No, sir.
Start sharing.
Sir, start sharing screen, sir. Click on share screen, sir.
Yeah, entire screen.
Now go to your, we are able to see your screen, but go to your presentation, sir. Now go to slideshow, sir. Yes, sir. Yes, sir.
So can you see?
Yeah, go ahead.
The positional lateral position, that slide you can see, right?
Yes, sir.
Positional lateral 8% and B chair 16.5%. This slide is visible, right?
Yeah, visible, sir.
Yeah, okay, thank you. So, as I told, the lateral position is more, it is less prone for recurrence. That is, lateral position only there is 8% chance of recurrence, and B chair is 16.5%. And the anchor position, a very important anchor position, the most important is said to be a 5 o'clock anchor position, in which the IGHL also gets tightened, and the number of anchors is always more than 3. So many papers say that less than 4, maybe sometimes 4, but never less than 3. That is, the number of anchors are always more than 3. And to address the humeral defect by measuring the hill sack, that is, the hill sack should be measured. That is, with a graded probe, you can measure the hill sacks. The volume, if it is more than 250 millimeter cube, it is said to be a massive hill sack. So, if it is engaging or non-engaging, it should be addressed. So, that is the latest papers which are saying that it should be underwent Rumpel's as, and this massive hill sack is another detrimental factor for redislocation. And we usually do the evaluation of glenoid bone loss is definitely done. That is, if the glenoid bone loss is more than 20%, we obviously go for a bony procedure like Latardy. And if the hill sack volume, as I earlier told, that is also very important. So, if it is less than 20% only, we go for a arthroscopic Bankart repair. Then recurrence rate is more in ISIS score, that is instability index score, that is instability severity index score, the ISIS score. If it is more than 5, there is high chance of recurrence. So that is a 10-year follow-up study of arthroscopic Bankart repair for initial shoulder dislocation in young patients. So this is the ICE score in which you tell the prognostic factors in which the age is less than 2, it gives a point of 2. And if it is more than 20, age is less than 20, it gives a point of 2, and more than 20, it gives a 0 point. And the complementary scores, it is 2 points, and recreational score, it is 0 point. Type of score, that is contact or forced overhead, it is 2 point, and in other scores, it is 0 point. Shoulder hyperlaxity, also it gives 1 point. And a hillside lesion on AP X-ray, that is very important in ICE score. It is visible, whether the hillside lesion is visible in external rotation view in the AP X-ray, it gives a 2 points. And if it is not visible in external rotation view, it gives 0 points. And the glenoid loss of contour on AP X-ray, that is also, there is loss of contour, it gives 2 points, but there is no lesion, it is 0 points. So total is at 10 points. So if it is less than 6, the acceptable recurrence rate is less than 10%. If it is more than 6, the entire score goes more than 6. The recurrence rate of 70% with the arthroscopic reconstruction. So this can be very useful in predicting the possibility of a recurrence in a patient who undergoing arthroscopic surgery. So another many studies conclude that early repair is another good prognostic factor. That early repair after initial anterior shoulder dislocation gives a more chance of non-recurrence of the dislocation. And another thing is subcritical bone loss, that is 13% to 19.8%. That's, we always know that after 20% of glenoid bone loss, you go for a bony procedure, and less than 20% you opt for a Bankart repair. But there is a new concept, that is subcritical bone loss, that is 13 to 19.8% in contact athletes. Also, you go for bony procedures, because in this patients, if you do arthroscopic Bankart, there is high chance of failure, says most papers. So, in contact athletes, if the critical, that is subcritical bone loss, that is 13 to 19.8% bone loss in glenoid, you go for bony procedures. And in this another Porcellini study, like 625 patients, the unidirectional instability is a study prolonging almost 10 years from 2009 to 19. So, this age, sex, and first time since dislocation. The time since first dislocation were more important. It was given more importance. So, in another study, in which the recurrence rate is more first time or recurrent dislocator. So, that is another comparative study. That's the outcome of arthroscopic Bankart. First time versus recurrent dislocation. So, obviously, the first time dislocators had better results because the glenoid labrum was more healthier maybe. The first time dislocators were having better results. And whether any association between Bankart repair and glenohumeral arthritis. So some studies are conducted at the long-term results between the Bankart repair and glenohumeral arthritis are studied. So actually it showed that there is no conclusive evidence between these two. These were the reports of the papers. And another thing, that is the hillside lesion, whether it is an off-track hillside, is it a risk factor? On-track and off-track hillside. So, is off-track hillside a risk factor? So, many studies compared all these things, and the off-track hillside is also a risk factor of recurrent dislocation. That was the conclusion. That is, off-track hillside is a significant and important risk factor for recurrence of instability and need of revision surgery. So, level 4 evidence were shown in it. And as we know, the very famous papers of Bankart, he described the inverted tear glenoid and engaging hillside lesion. So these two were very much important in deciding whether the arthroscopic Bankart will fail or not. The inverted tear glenoid and engaging hillside. So both, that is inverted tear glenoid, as we all know, the anterior-inferior portion of the glenoid rim is lost, then the bone is lost, and the normal pear-shaped glenoid is changed into an inverted pear-shaped glenoid, and that is a risk factor for high risk of recurrent dislocation after arthroscopic Bankart repair. So inverted glenoid and the engaging hillside, that is both are high risk. And another thing is that, as I earlier told, there is some subcritical bone loss. That is, if the bone loss is not more than 20% and it is not as less as 15%. So there is some papers told that, like Philip Moroder from Germany. He devised an arthroscopic Bankart plus procedure for treatment of anterior shoulder instability with small to intermittent glenoid defects. So what his concept is that even though the glenoid defect is small, and if it is not addressed properly, it could produce some instability. So he intermittent, this is called small to intermediate glenoid bone loss. So he actually put some synthetic bony materials in between the Bankart repair and the normal glenoid bone, so that much of bone is augmented, just like a bone graft, but it's a synthetic one. So it's an arthroscopic Bankart plus procedure for the treatment of intermediate glenoid bone loss, so that even after arthroscopic surgery, it will give more stability and less chance of dislocation. Another thing is that glenoid loss is considered to be a tip of the iceberg, because most of the CT analysis studies, the prevalence, pattern and spectrum of glenoid bone loss in anterior shoulder dislocation was found to be far more than it could be seen in X-ray. So CT analysis of these glenoid bone loss showed that the 33% of people had 10 to 12% of first time dislocators had more glenoid bone loss in it. There's a CT study. So thank you for the patient listening. This is the evidence-based talk regarding the etiology of glenoid dislocation. Thank you.
Thank you.
Thank you, sir.
Thank you, Jyoti. I just have one question. What is your preference or what the evidence says in athlete with 15% bone loss? Are they going for bony procedure or are they going for soft tissue procedure? This is a kind of subcritical bone loss I am asking about.
Sir, athlete, whether he is a contact athlete, contact sports.
A little controversial only I am asking you. A 15% bone loss in an athlete, young adult.
Sir, is he doing a contact sport or non-contact athlete?
Okay. Ali, please, you go ahead.
Yes. May I ask a question now? Maybe stimulate the talk a little bit. For all the faculty, please.
What is your view on bone loss?
In the case in your case, I would definitely go for lateral J. I wouldn't risk it with a Bankart repair. But I have a question to our colleague. Yeah, thank you for the talk. Do you know any results of lateral J after failed Bankart repair? How do they do? Do they do better than an initial lateral J? For example, if you have a case where you would do from the beginning a lateral J, and another case who has failed the Bankart and now is doing a lateral J, do you have any data supporting which one does better?
Well, I think definitely the one which has had a primary lateral J will do better. Because failed Bankart lateral J is going to be even more worse. I mean, there is no other option for failed Bankart, then you are going for lateral J. But if you compare primary lateral J and failed Bankart lateral J, probably primary lateral J will do better.
Very interesting what you're saying. I think you are right, but there is no data to support what we are saying. So we do not know. Some people do a revision open Bankart. Some people do a revision Bankart plus Hill-Sachs remplissage. Some people do a revision anterior glenoid bone augmentation procedure plus Bankart, not a lateral J. That means they attach some bone, as our colleague nicely demonstrated, and then redo a Bankart over the top. So there are many techniques, but the question is, if there is any data supporting that. I agree with you, my feeling as well, that lateral J does better from initial choice over a failed lateral J where there is some arthritis or some extreme bone loss or some cartilage wear.
Yes. Akil, you are ready with your talk? Akil, are you ready with your talk?
Yes, sir, I'm ready, sir.
Next talk is going to be actually even more interesting.
Am I audible?
First time dislocator. Always been a controversy intervening on first time dislocator. So let's see what the evidence says about. Dr. Akil, you please start sharing your screen.
Yes, sir. Screen sharing okay?
Yes, sir.
Okay. So first of all, I would like to thank Dr. Subramanian sir for giving me this opportunity to talk about intervention in first-time shoulder dislocation. What evidence is. Usually in orthopedics, there is always a lot of controversy, and this is a wonderful series started by KN sir, 3 series where evidence, experience, and expertise are mattered, and I am going to talk about this evidence in first-time shoulder dislocation. Just a decade ago, where in 2006, Chong conducted a survey UK, where almost 90 specialists were asked about what are their management choices about shoulder dislocation, and of which it can be clearly seen that in less than 20 years of age, 68% preferred to do conservative management, and in 30 to 65 years, more than 82% preferred to do conservative management. So, but recently there is a move towards surgery for initial first dislocation, and we are just going to see what is the reason for this, and whether it is true, whether we have to do surgery for all first dislocation, or whether is there anything else. The reason for why we have shifted to surgical is because of recent studies shows that this Kavaraj, where he had conducted a systematic review based on the PRISM reporting for systematic review, where 2 randomized trials were conducted, in which he had shows that patients who underwent surgery to repair a labral injury had fewer dislocations than patients who received non-surgical managements or arthroscopic lavage. Even after 1 year and even after 2 years, patients who had labral injuries had significantly had lower dislocation for first-time traumatic shoulder dislocation. Randomized trials have shown that surgery is a preferred treatment for first-time shoulder dislocation. So acute traumatic first-time shoulder dislocation, why AFS has to be treated. Research has, there are a lot of reasons why first-time shoulder dislocations has to be treated, but one of the important things that the literature talks about is recurrence and complications of recurrence. So recurrence, as everyone knows that age has an significant impact on the recurrence of shoulder dislocation. Shoulder dislocation, as general, occurs in as a bimodal distribution. This data from Rovi shows that an analysis of 500 patients, patients who are aged 11 to 30 years have more recurrent dislocation, have more dislocation, and the older age group, more than 60 years, have more shoulder dislocation. Compared to the recurrence, patients who are less than 20 years have a significantly higher risk of recurrence. This article was published in the year 2000, and recent literatures are even shows that patients who are less than 40 years of age have more chances of dislocation, reaching even up to 70 to 80%. So this complications of recurrent dislocation is there is 2 that literature says. One is that capsular laxity and the development of osteoarthritis. Capsular laxity, this Palak in his biomechanical study, which they have included 33 fresh frozen human cadavers. They have separated each cadavers into group 1, group 2, and group 3. And they have studied about the impact of continuous cycles of stresses on the inferior glenohumeral ligament. And they have shown that ligament elongation occurred with cyclical testing at which are sustained at all 3 groups. And even after the residual length increase was observed in all the specimens and appears to be unrecoverable. So the reason for this capsular laxity is seen from this data from Bakerman, where he has shown that this type of collagen, as the patient grows older, the type of collagen changes. Collagen type 3, which is an elastic collagen, is more in the birth, and as we reach adolescence, it begins to decrease, and as we get to older age, it is almost completely vanishing, and the type 1 collagen increases. As these collagen is elasticity, patients who are having dislocation at a younger age, they develop recurrent dislocations. And development of osteoarthritis with recurrence. This is a Swedish multi-center study from 1978 to 1979, one of a landmark article published by Hovelius, where they have followed patients for almost 25 years. They have shown that shoulders were normal in just 40% of this. This means that 66% developed osteoarthritis. All these patients, 257 shoulders, they have no treatment. They were just raised for 25 years, and X-ray done showed that the 29% has moderate osteoarthritis, and 9 developed moderate osteoarthritis, and severe osteoarthritis was there in 17%. So, just as I said, there is a controversy. Even after for surgical treatment, some of these patients who had surgeries, 62 patients had surgeries, of which 26% had development of osteoarthritis. So, does this mean all the patients with shoulder dislocations has to be treated surgically? The literature again shows that there are few factors which can decide about doing a surgery or conservative management, but these are all literature based. There is a meta-analysis done by all this, published in the year 2015, where they have almost included all the databases available, even Scopus and the Web of Science. They have included 10 studies, which comprised of 1,324 participants. And their main study inclusion criteria was for a follow-up of more than 1 year. And all these patients, they had no surgical intervention was done. And so this group, which shows that 7 studies were included in this, and all these studies shows that patients who are of a younger age, they have an increased chance of recurrence, and even up to 40 years, there is a 36% chance of recurrence. As we get the age increases more than 40, the chance of recurrence decreases significantly. The next thing that they concluded is sex. The 7 studies which compared that between the male and the female shows that shoulder instability has a recurrence rate of 46.84% men, compared with just 27.22% in women. They concluded that men were found to have 3 times more risk of recurrent instability. Then there were a few other associated factors which suggested that there were more chances of recurrence, of which greater tuberosity fracture. It was found that patients who are having greater tuberosity fracture, they have of redislocation, and this showed that the data showed that people with greater tuberosity fracture were over 7 times less likely to suffer from recurrent instability. And patients who are having a heel lesion, they are more likely to 1.55 times more likely to have recurrent instability. And the patients who are having nerve palsies, like the axillary nerve or brachial plexus nerve, are 2.49 times less likely to suffer from instability or everyone has shows that if a patient has developed a dislocation, and if it is more than 2 years, then the chances of dislocation reduces significantly. And the patients who are having hyperlaxicity are 2.68 times more likely to have recurrent dislocations. So the summary of their meta-analysis is age less than 40, 13 times more likely to have a recurrent dislocation, men 3 times more likely, greater tuberosity fracture 7 times less likely, and hyperlaxicity 3 times more likely. Except for greater tuberosity fracture and nerve involvement, everyone is more likely to have a recurrent dislocation. So in that meta-analysis, they were not able to include the level of activity because reporting of the level of activity varied between all those 10 papers. So this was published in the year 2006 by Raymond. They have included 131 patients, of which 43 had at least one recurrent dislocation. Of these 43 patients, 39 of these patients were less than 40 years of age, and of these 39 patients, 37 participated in either contact, collision sports, or arm above the chest level is their occupation. This shows that significant impact on the redislocation rate with the level of sports or activity that patient does. The associated lesions, as everyone knows and previously has talked by the previously talked, that dislocation associated with either Bankarts or heel sacks or more prone for a recurrent dislocation. First-time traumatic anterior sole dystonia systematic review shows that there is a chance of a heel sac lesion in 54 to 100% of first-time dislocation. And glenoid rim fractures occurs in 1 to 4 to 22% in first time dislocation, and greater tuberosity fractures in 16% in first time shoulder dislocation. So these are the factors which has to be considered while treating a patient for first time dislocation. So the treatment option would be either non-operative management or it could be an operative intervention. Non-operative management, this was again a systematic review done by John E. This was published in the year 2012. So the best reduction technique, they were not able to conclude because all the reduction technique, as the surgeon is comfortable, will reduce the shoulder. And the pre-medications, we can use either intra-articular or IV sedation, and the comparison between is there is no difference in the success of reduction. But intra-articular lignocaine consumes less timing than IV sedations, and IV sedations can sometimes cause complications, but it was statistically insignificant. Then there is another controversy in first-time dislocation whether to immobilize the patient in external or internal rotation. There are multiple articles supporting that patient has to be kept in external rotation. Etoyi in 2002 published that did a randomized controlled trial of more than 198 patients, of which they kept 94 patients in internal rotation and 104 patients in external rotation for 3 weeks. And they showed that there is a statistical decrease in the number of patients having recurrent dislocation by keeping in external rotation, and the relative risk reduction was around 46.1%. This external the scientific reason for keeping in external rotation in the first time shoulder dislocation was done by a cadaveric study by Miller, where he did the contact force between the glenoid labrum and the bony glenoid and the labral tissue was measured in 0 degree, 45 degree of external rotation and 60 degree of internal rotation. They showed that external rotation significantly increases the glenoid labrum contact force and may influence the healing of a Bankart lesion. So the period of immobilization is a little controversial. There are multiple studies which shows that there is no influence on the period of immobilization. There are studies which shows that even with the 3 to 4 weeks of immobilization, there is no difference in the dislocation compared with the patients who are not immobilized. So operative intervention, the operative treatment for first-time shoulder dislocation based upon the factors which has been previously explained would be Bankart's repair or bony Bankart's repair. Arthroscopic lavage is of history as no one does this, and this was once thought to reduce the chances of dislocation as it eliminates the hemorrhosis and promotes capsular labral complex of glenoid. But as of now, no one is shoulder instability. To conclude, this is a landmark study published by Hobelius, where they have less than 40 years of age and younger were followed 25 years. None of these patients had surgery. They were followed for 25 years, and they showed that 99 of the 229 shoulders had not redislocated, and 17 redislocated once. So after a period of follow-up for 29 years, only 43% had a dislocation of all these patients who are less than 40 years of age. And this was a huge controversy, and this has been cited by many articles. And I would like to conclude by thanking Dr. Subramanian sir. And as for orthopedics is a lot of controversy, this topic is also a controversial topic, and I would like to hear about what the experience and expertise would like to share about their thoughts. Thank you.
Thank you for the talk, Dr. Akil. It was very interesting. I will cut in, maybe Dr. Subramanian is not so close to the computer. Thank you for this nice talk. You covered the evidence very well regarding the anterior shoulder dislocation. So just a question for you. Now, what do you do in your daily practice? Do you operate all the first-time dislocators, or do you wait and immobilize in internal or neutral rotation? What do you do now? What has this changed, or what do you think you will change?
I think based on reading after all the articles, I think there are multiple factors which has to be concluded when treating a first-time shoulder dislocation. Mainly, the age is a factor.
So imagine
the level
I
of
came to you.
The two important factors which has to be considered.
Sorry to cut you. Imagine that I come to you to the clinic. I am 40 years old. I am hyperlax, and I play tennis. But I'm like every week I play in the weekend. I do not play matches. I do not play. And I have one episode of anterior shoulder dislocation. And you do the X-ray and and all the X-rays, the AP, the lateral, the axillary view, and you find I have a small Hill-Sachs lesion.
Okay.
And no anterior glenoid bone lesion. So what would you do to me? How would you treat me? So this is a real life scenario. Analyze the data that you just provided us and tell me how you treat a 40-year-old male who plays occasional sedentary sports and hyperlaxity with small Hill-Sachs lesion.
With occasional sports and hyperlaxicity, then I think I would like to discuss with the patients the treatment options. I would explain them that since they are hyperlaxicity, they can change their lifestyle and avoid playing sports or keeping their hand in abduction external rotation. But if they insist on playing sports, then I would like to do a surgical intervention for them.
Okay. If you decide to do the surgery, what would you do? For me, I am 40-year-old. What would you do for me? One anterior shoulder dislocation with a small Hill-Sachs. What would you decide to do?
Now, is there a bony loss in that?
Yeah, so he analyzed the data very nicely. Huh? I'm going to explain to you the story. So I'm telling him, I'm trying to let him use the data that he just gave us in a real life scenario. So I told him about me. I am 40 years. I play occasionally some tennis, and I fell and I dislocated my shoulder, anterior shoulder dislocation. And he saw me in the clinic, and I have a small Hill-Sachs lesion and no anterior glenoid bone lesion. So I told him, how would you
if there is no bone loss, I would go for arthroscopic
small Hill-Sachs.
Doesn't matter. I'll still go for Bankart repair, arthroscopic repair. If there is no bone loss.
Okay.
Because you are changing the anatomy if you are doing bony procedure.
Yes. I wanted Dr. Akil to analyze the data he just gave us.
Okay.
So he did that very well. I know, Dr. Subramanian, you're an expert, so you will know the answer. It's very nice. Thank you.
Prajwal, yes. What is your question?
Sir, a 50-year-old male who is a farmer, he comes with 4 days post dislocation, which is the joint is still outside, with both rotator cuff and anterior Bankarts, bony Bankarts. On MRI, the bone loss is not crossing the limit. It is around only 14%. So what would be the treatment management? He has both rotator cuff and bony Bankarts.
When you have scenario like both Bankart as well as cuff, in a 58-year-old, your priority goes to the cuff. Okay? Because we are looking for range of movement at the end. If he has got full thickness cuff tear, we need to repair the cuff. But if I am going arthroscopically, if I have a chance, I'll repair both. Do cuff as well as Bankart also together. So that will be my option. But the priority will be given to the cuff for me rather than Bankart. It's a first time dislocation, isn't it?
It is recurrent. I mean, for second time, but it is like 4 days, the joint is outside only. Post dislocation.
It's not chronic, but still. In 4 days, sometimes it won't go that easily also. So you try for close manipulation and see. If not, then you'll have to open it.
If we have done the rotator cuff and post-operatively maximum external rotation, the joint is still slipping out.
After doing cuff repair?
Yes.
Oh, then you need to repair. You need to address glenoid also, because there is a bone loss in the glenoid, you said.
Yes, sir.
Then you will have to address that bone lesion also. You have to do repair of the anterior damaged structures. This is after doing a open repair or after doing
Open
repair. Okay. Yeah. Is it we went through deltopectoral approach or which
split approach? Deltoid split.
That is difficult then, isn't it? If you go to split approach, makes life difficult. What is your view, Ali?
I think you summarized it very well. I would first tackle the rotator cuff. So I would first tackle the rotator cuff, reduce the joint first. He's dislocated since 4 days. That means I will have a hard time reducing this joint. And I would probably, if I'm going to do an open rotator cuff repair, I would think of the deltoid split if I'm going to do something for the Hill-Sachs lesion. And you know, sometimes putting your anchors on the Hill-Sachs defect can also do a sort of remplissage when you fill in the infraspinatus as a repair. And that could have been a good idea if you would have thought of that inside the surgery to address the Hill-Sachs lesion, which most definitely would be there if you had an anterior shoulder dislocation. And you would insert your posterior medial anchors into the defect and use the rotator cuff as a remplissage, as well as repairing the cuff in a double row transosseous equivalent technique. This is my opinion, I think. But if you have done what you did, and first you repair the cuff and the patient is still unstable, I am 100% agreeing with Dr. Subramanian that you should tackle the bone loss and maybe do a bone augmentation surgery, either iliac bone crest or Latarjet procedure. But 50-year-old, watch out because of healing.
Thank you, sir.
Good. Thank you. I think we'll go with the next talk, which is going to be Dr. Ali Maqdes, who is going to tell about his technique of surgical repair in shoulder instability. Dr. Ali, please go ahead.
Sure. Hi, do you see my screen?
Yes, we are able to see. Please go ahead.
Okay. Thank you, Dr. Subramanian, for this excellent webinar. I am very pleased to join you. It's my first time that I join this part of the world, and I'm really, it's my pleasure to present with you guys. So just a little bit, I have some disclosures to give you in this talk where I'm using Arthrex implants which are relevant in the videos. So I will talk to you on this talk about 3 techniques that I use in my daily practice: the anterior Bankart arthroscopic repair, the bipolar fixation with a Hill-Sachs remplissage, or the anterior Bankart repair plus Hill-Sachs remplissage, and the Latarjet procedure, which I do it in an open fashion. So as you have summarized very well in the previous talks, it's a very difficult decision to make whether to go for a Bankart repair, a Bankart plus Hill-Sachs remplissage, or a bony procedure like Latarjet or Ebenet, or augment with an iliac bone crest, or autograft, allograft, depending, or synthetic material if you wish, which is a newer techniques coming out in the market. So in real life, you are faced with 3 situations: whether you go for just a pure anterior soft tissue repair, you go for an anterior and a posterior soft tissue repair, or an anterior bone augmentation technique. So for an arthroscopic Bankart repair, I like to seat my patients in the lateral decubitus position. And this is what I do. I have a double pulley technique. I like to use a standard orthopedic table. I slide an axillary pad under the opposite shoulder. I make sure the head is nicely padded. I like to give my patient a little bit of posterior tilt. That means coming back towards me so that I can have access to the anterior structures. I use a traction device with double pulleys. And of course, I ask my assistant sometimes to rotate if I need to access the posterior part or the anterior part, even push and pull if I want to move the humeral head anteriorly or posteriorly. I usually use very standard portals. So here I have marked the posterior viewing portal and the anterior arthroscopic rotator interval portal, in which I introduce a cannula. Here is what I do in an anterior shoulder surgery, so a Bankart repair. Here you see I am starting through an anterior portal to start to liberate from the glenoid the anterior labrum using an electro-radiofrequency device. I progress very slowly but surely in contact to the bone, trying to keep the integrity of my labrum together and not rupture the ring. So I go progressively coming in contact to the bone from the anterior portal with my scope in the posterior standard viewing portal and slowly move down the glenoid neck from the 3 o'clock position at the inferior part of the subscapularis and slowly moving down. I liberate by pulling on my device to push up the labrum and, cut all these adhesive tissues that are adherent to the medial part of the glenoid neck due to the alapsa lesion or the chronic healing of the inferior part. You see this video is real time. I am showing you exactly how it takes. It takes a couple of minutes to release and go inferiorly as far as we can without rupturing the integrity of the ring. And you see appearing in the bottom there, this soft tissue that would isolate the labrum complex and the capsule from the subscapularis muscle. And slowly, as I pull harder and release, I would reach the level of the subscapularis muscle. I make sure not to go very inferiorly without having visualization because I'm afraid to encounter the axillary nerve on the other side. So it takes a while here to release, but you see that the labrum now has risen up to the level of the glenoid. I like to do a specific test maneuver where I use the rasp to pull on and release all the adherent tissues that are still remaining stuck, and avoiding that I use this as if I am using a periosteal elevator to avoid contact to the axillary nerve. And this would give me nice maneuverability, and I can start seeing now the muscular part of the subscapularis. So after I do this, with the same rasp, I try to revive the anterior glenoid neck so that I can get some bleeding bone, so that when I put in contact the labrum to the bone, I get a good chance of healing. I then stop the water, the arthro pump, and see to what level do I get the labrum to descend down to its original location. You'll see that in a minute. So here I'm still not convinced that I have released enough labrum until the bottom. I like to go very far down, honest to say, because my aim of the surgery is not just to repair the labrum, but to create a south to north shift. That means I like to pull all the glenohumeral ligament, the inferior one, and tighten the space on the joint. So here you see me closing the water, and you see that the labrum is descending very slowly without the pressure of the water, but it's not going beyond the rim of the glenoid. Now, this is how I pass my sutures. I introduce an automatic suture passing device. I grab the labrum, and I pass a first initial suture that I can use as a traction suture. And with the suture under traction, I can release more inferiorly, going down even further than the 6 o'clock position And sometimes I can reach to the inferior 7 o'clock position, staying in my anterior portal and not moving my portal. See, if you keep it simple, you can do it very nicely. So here I'm going and I'm passing now the curve of the glenoid to make sure that I am as far as I can go and pull at as much tissue as I can before going on to the repair. So here I clean up what I can to get the maximum sort of inferior capsular release that I can get. Sorry for the video, sometimes there are some changes. So after having done that, and I am satisfied that I have released all, you see my traction suture, I now introduce a second suture, which will go even more inferiorly and really get that inferior glenohumeral ligament anterior band, pass that suture through and create a cinch. You see that cinch stitch, I introduce my drilling guide through the anterior portal with the cannula, use that drilling guide, introduce a hole into the anterior part of the glenoid. I try not to be too anterior into the middle of the glenoid and stay very close to the rim. After removing that, I introduce an all knotless peak anchor of a small diameter, 2.9, that I can impact nicely into the bone and tension, as you see, as I go in, tension the labrum nicely into its original position. After doing that, you just impact the introductor. You impact the introductor and continue by impacting the anchor. So this will really tension up all the inferior glenohumeral ligament. This would stay completely flush into the bone. It usually has a very nice grasp. My first ankle would probably be at the 5 o'clock position and then at the 3 o'clock position, and I stop at the 1 o'clock position. To be honest, I have never used more than 4 anchors. I usually use 3, and if I have a superior labral tear, then I might add 1 or 2. Cutting the sutures flush would add to avoid any knots into the joint. So this would give me a very nice repair of the labrum if I do 3. And what does it look like at the end of the surgery? Well, if you look, this is the end of an arthroscopic Bankart repair where I have used 3 anchors, and you see the stability of the labrum with the tension on the labrum at the locations where we have placed the anchors. So that was just a brief of the anterior Bankart repair. I do it really simple. I don't like to do many portals, and I stay in the technique as I showed you with an automatic passing device and a knotless suture. Now I want to show you what I do if I'm going to do a Hill-Sachs remplissage. So I use the normal posterior viewing portal. I also use the anterior working portal where I introduce a cannula. And I also use this posterolateral Willington portal, which I will show you now in the video. So you see my needle now going through the infraspinatus tendon, and just small hole of the needle, I revive the Hill-Sachs lesion that you see in front of you. So through the hole, I am just removing the remaining cartilage. I am viewing from the posterior portal, so there is nothing magic here. I just ask my assistant to push the arm anteriorly. Through that same hole, I then introduce a small 2.9 metallic anchor at each extremity of the Hill-Sachs lesion. So at the inferior part, you see me introducing the anchor there, and I like to seat it well into the bone. It contains 2 sutures. And then I do another one at the superior pole by passing through another hole into the rotator cuff, but not making sure that the holes are very minimal and not big, and that's why the choice of a small anchor. If I pull on the sutures, you see what happens? The cuff comes and sits nicely into the defect, filling up the defect. After I do that, I go and attack my anterior Bankart. I leave the sutures to the back without having done them. I repair my Bankart in the same fashion. I do 2 or 3 anterior Bankart repairs, and I go back, turning back to the Hill-Sachs lesion again at the back of the shoulder. And now I start tying in my sutures. If you want, you can do a subacromial bursectomy before that position to avoid that you get any interposition of the deltoid. What you see me doing here is that I have tied the bridge of the two sutures together. That means one limb of each suture has been tied together, and just nicely pulling on the two others would come and sit the tendon in a parachute-like technique directly on the Hill-Sachs lesion, filling it up very well. As you well see now, you cannot see. You probably now see me tying on the suture, and I show you what it looks like after I have tied the sutures. There is no more Hill-Sachs. The cuff is completely sitting onto the bone, and here you see the anterior Bankart repair that we have done in 3 knotless technique fashion. So this concludes the way that I do the Bankart repair, the bipolar fixation. Now for the last one, I would like to show you my video regarding the Latarjet procedure. And this is how I place my sutures. That my patient, I like him flat on the back, nothing fancy, no beach chair, nothing, no arm holders. And I slide a small pillow under the medial scapula. I try to bring the patient very well to the outside of the table and have 1 or 2 assistants helping me in the surgery. So I'll take you through the surgery. So I do a mini deltopectoral approach, which is approximately 5 centimeters, centered over the coracoid process. I go through the rotator interval. I nicely dissect until I see the conjoint tendon. I then release the lateral part and place the Hohmann's retractor on the top of the coracoid process. I then release the coracoacromial ligament by doing an abduction external rotation maneuver so that it will help me to close at the end of the surgery. I then move to the medial side and release the pec minor from the medial side until I reach the knee of the coracoid process or the curved part of the coracoid process. This part is scary for many because of the proximity to the brachial plexus, but I tell you, stay close to the bone and you would have no problem. I then use a curved saw and take about 2 centimeters from the base of the coracoid, making sure that I get enough length. After that, I complete my osteotomy using a curved osteotome. I then grab onto my coracoid process, turn it around, and start cleaning the undersurface, removing all the adherent tissues, and making a flush surface. So I hold it with this nice holder, and I remove all the undersurface tissue that you see under. And then with a straight saw, I complete the osteotomy, making the coracoid process quite flat. I measure, and it's about 2.5 centimeters in this gentleman. I use this nice guiding device, which gives me 2 parallel holes to be able to be placed. I tag them very well and place a suture in them to find my coracoid process when I'm down deep into the glenoid. I then go to expose my subscapularis to be able to split very well and show the well. I go to external rotation. I clean up all the tissues in front of the subscapularis. I identify the superior part and the inferior part. And then I go 1/3 inferiorly, 2/3 superiorly, and do a horizontal split of the muscle at the level of the glenoid. I then split the muscle fibers with a blunt dissector and introduce a gauze into the scapular fossa. This will create a nice working space for me. And as you see here, the capsule is very clearly identified. I insert my gauze that is tagged with a suture so I don't lose it in the end. And I keep it tucked in there to avoid the bleeding and to create a nice working space. I then place a nice deeper retractor into the split and start doing the humeral head arthrotomy. So I do a vertical arthrotomy. I introduce a specific retractor to retract the humeral head And now I see very well the anterior glenoid wall as you see in front of you. I resect all the remaining tissue. I revive everything using a curved osteotome. This will probably give me the nice desired effect of a clean neck of the scapula. The next step is to just introduce your bone block. So pulling on our sutures is very easy now to find it. I remove now the sutures and introduce this aimer that has two parallel K-wire wires that I can place. And I like to be very flush to the glenoid cartilage. It usually looks weird from somebody looking at the outside because the position is very parallel. And then we go and place two K-wires parallel. I drill over them with a 3.5 drill hole and introduce two 4.5 cannulated semi-threaded screws. I then close very well my coracoacromial ligament to the remaining part of the humeral capsule. This will complete my repair. I do this in external rotation. Remove the gauze and start closing up my patient without a drain. You see the effect of the conjoint tendon as the rotation comes from medial to lateral, and you see my incision is not more than 4.5 to 5 centimeters. So this concludes my talk with you guys about the techniques that I use in the everyday procedures in anterior shoulder instability. I hope that helped. Thank you.
Thank you, Dr. Ali. It was I enjoyed watching your
You're welcome.
All the 3 videos, especially the arthroscopic.
Thank you very much. You see that technique is very easy.
Almost similar technique I do, because you are using the suture scorpion to take your inferior stitch. Almost similar.
I use it for all my stitches.
Yeah.
It's very effective for me to catch the labrum.
Yeah.
The only problem I face is when the labrum has a piece of bone. And if there is a bony Bankart there, then this is a little bit more tricky. And in that case, I go to the conventional suture hook lasso technique where I pass around the bone and come out. But I think for somebody who is not doing too much Bankart repair, the use of an automatic suture passer is very effective. Yeah. Start with using these things. It will help to get a good grasp. And do not hesitate to pass twice. That means do not be afraid if you think that the first initial pass is not enough, to keep it on a pull and then go inferior to it and pass another one. And this would give a better pull on the inferior capsule.
Any questions? Anything else? And just one more thing, when you are working on the glenoid margin, anti-glenoid margin, I saw you using the radio frequency cobblator to, I think you try to denude the cartilage to some extent, is it probably? Few millimeter?
I don't like to touch the cartilage, honestly, but in real life, sometimes we do touch at the cartilage level. It's 2 scenarios. If I sometimes see that the labrum is completely detached, like the case I showed you, it was very easy to introduce my cobblator into the neck. Sometimes you don't see this sort of picture. You see that the labrum is maybe detached at the inferior part, and here I'm afraid to use the cobblator straight away. I have 2 options in that. Either use the hook, which will have a smaller margin of cut, or start by using the periosteal elevator and with the hammer, release it. Exactly. Tap a little bit, release, tap a little bit more inferiorly, release, and then insert your cobblator and start working on the neck. And with the cobblator, I have the maneuverability to push on the labrum like this and elevate. So slowly I elevate and then go in more and elevate and go in more. It takes 5 minutes if you really master it, and it gives a really good release, and there is no bleeding because you coblate as you work. But if you do it bluntly sometimes you get the bleeding from the muscle, and it comes into your face and you don't see anything anymore.
I think the important point
And we are,
the beginners is one has to shift the camera from the posterior portal to the anterior portal. Only then you can have that good visibility of seeing right up to the inferiormost capsular area to see the subscap muscle. So the most important point is you have to see it from the anterior portal. Then only you'll get that good visibility.
or use a double traction in the lateral position. See, all that I have done here is in the lateral decupitous position with a double traction pulley system, and my scope was always in the posterior part. I don't change often, to be honest. I stay always in the posterior part. It simplifies my life. It helps me. But if you do a beach chair position, then I agree with you. You need to come from the anterosuperior portal, or you do not see the inferior margin unless you have a very strong assistant who pulls and does the abduction, and it's very tiresome.
Jyoti, you want to say something?
You're muted.
Jyoti, you are muted. Unmute.
Sir, in inferior 5 o'clock position, you use the knotless angle. So, what all angles, other angles you put? Do you use all suture angles or knotless angles?
Yeah, so I've been experimenting now with the knotless, all suture knotless technique. There is a new sort of anchors now in the market, which are all suture and knotless. That means you don't need to do a knot and come down. The only problem I have, which is a very good question that you faced, at the 5 o'clock, if you use a knotless anchor like the one I used, the push lock, be careful that you might exit at the inferior part of the glenoid. And I have seen this happen once, that we got an inferior glenoid fracture because you start at the rim and you pierce at the inferior glenoid, and with the tension that we applied on the post-op x-ray, we saw that the fragment has moved. And be careful of that, because you can create a fracture into the medial, into the inferior part. So be careful of how you place your guide. Now I use the short version of the push lock, which is not the regular 17.5, but it's a smaller 12.5 millimeter anchor. And this gives me a less hole to drill, and I'm no longer afraid of cutting through the bone at the inferior part. If you like, you can use the curved devices, which also are very nice, but we don't have a curved, knotless anchor up to today in the market. It does not exist. We have a curved suture, normal suture technique, all suture anchor. And I am not a fan of suturing because I cannot master the tension. And I am afraid that the knot might flip into the glenoid side at the end of my surgery and create arthritis in the long term. So this is some of my concerns that I think for my patient every day. That's why I am a fan of the knotless technique.
So in bipolar lesions, when you have to address the hill sac and also the glenoid, so the first anchor you always put is in the hill sac for rumble stance. So preoperatively itself, have you decided that you should go with a rumble stance as Bankart repair, or can you do it reverse also? After Bankart repair, it is very difficult to do a rumble stance because the capsule will be always tight. So do you always preoperatively decide?
Yeah, so I like to decide preoperatively, definitely. I always decide preoperatively. For example, if I have a 40-year-old recurrent shoulder dislocator with no anterior glenoid bone loss and a Hill Sachs lesion, I would decide definitely for bipolar fixation. If I had a 20-year-old, I would do a lateral J procedure. If I have a 25-year-old with just an anterior glenoid bone loss, anterior glenoid lesion, I would do a natural Bankart repair. In my practice, lateral J takes 75% of my work, and only 25% goes between Bankart and Bankart replissage. I always decide preoperatively. This is one thing. And the second question, the second part of your question, the sequence of doing the bipolar fixation is very important. As you enter the shoulder is still very small. It's not swollen. You can access the posterior part very easily, and you will not lose yourself with the difficult positionment. You put in your anchors, and then you're happy because the difficult part of the surgery, the remplissage, is done. You go attack your anterior Bankart, You finish your anterior Bankart, and then you just knot down your posterior part, which is at the end of the surgery takes 5 minutes. Do not be too optimistic by doing the Bankart first and then attacking the remplissage, unless you are an expert at what you do and you know how to manipulate the shoulder. And usually you will need to do an anterior superior approach to be able to do that. So this is my tip to you.
Just to go inside and see the glenoid rim is totally gone. Will you augment with a subscap or any other options? That is, the glenoid labrum.
Sorry, can you repeat? Can you repeat your question?
Sir, you go inside for a glenoid arthroscopic Bankart repair. You find that the glenoid anterior rim is totally damaged. It is not that much repairable. That is, could be an ulcer lesion that has gone down and it is totally irreparable. Will you consider subscap augmentation or biceps tendon augmentation or anything?
I've never done it in my life. I have a good eye for these. These usually patients are young males who are hyperlax. These are usually the scenarios. Young males hyperlax. These are the scenarios that you have an attenuated labrum or no capsular tissue in the front. And to be honest, I don't change my indication. I do what I told them I would do. I do an anterior Bankart repair, and I tell them, unfortunately, I'm not very happy, maybe, and maybe you will get a recurrence. And if you get a recurrence, then we can do a lateral J procedure. I do not change what I like to do in the middle of the surgery. It's a huge risk for me because at first I am not prepared. Secondly, the patient is not aware. And this can create a lot of problems for me. I do what I say, and I tell the patient honestly, I got shocked by the rate. For me, I have the luxury of videoing every surgery. So if I have a doubt, I show the patient. I tell him, come, look at your video. Look at the surgery that we did together. And this is what I found out. And I give him a copy. I tell him, this is the USB. You take a copy of your video. And you can decide to show any other person. I am not afraid of my work. I tell them the honesty. So this does not give me any problems in case I am facing a difficult situation. And all of them accept, they say, okay, we'll try and we'll see. If it happens, it happens. If it doesn't, it doesn't. With time, you will learn that these patients are bad. They have bad tissue, young males with many, many recurrent dislocations, 20, 30, 40 times. And they dislocate when they sleep, they have hyperlaxity. These patients, be aware not to go for an anterior Bankart repair because the tissue would probably be very flimsy, as you said, very thin, attenuated, and no matter how tension you put, it will all go back to looseness.
I think, Jyoti, your scenario is not uncommon in our part of the world because we come across patients like 30 to 40 dislocations and they are having very flimsy tissue in the anteriorly. I think that kind of scenario, better to go for a bony procedure rather than going for a soft tissue augmentation because we don't have any standardized work about doing subscapularis augmentation or biceps augmentation as of now. If you think there is not much tissue in the front, you better go for a bone procedure.
30 to 40 dislocations, there already will be a off-track lesion.
Yes. It will be even
Hill will be very big. So
yeah. You should convert an off-track into on-track by replacing the anterior bony lesion only.
The question that might be the next part of the same question is, who of you does a diagnostic arthroscopy before deciding?
I think totally out of question for me. I don't do diagnostic arthroscopy at all. Because we all
some people
their conclusion by seeing MRI pictures and the CT scan. And
definitely, that is right.
Yeah.
The only person who can do a decision intra-op between a Bankart, a bipolar, or a bony procedure is the person who masters the arthroscopic lateral J or the arthroscopic Bristol procedure. Yeah. And in that position, you have the choice to go between all techniques operatively. So you can go for the surgery and you tell the patient, well, I would do. This has now happened in the shoulder arthroplasty world. Because a lot of surgeons say you need an arthroplasty, but when I open and see that the cuff is not so good quality, I would do a reverse. But if it's a good quality, I would do a total. So this is another issue that a lot of people do because of the possibility of the convertibility. And maybe this will come up in the future, that indication would no longer matter preoperatively, as the techniques will all be arthroscopic. And you can go in and tell the patient, well, I will do one of the three. And when I'm in, I'll decide. In the future, we might need to think that way.
A totally different subject to talk about, because people are extending reverse shoulder now even to those with cuff intact but still having malfunctioning cuff. They are going for a reverse shoulder. The extensions are happening.
I'm one of them.
Yeah. I think good.
Very interesting debate.
Yeah. If there are no more questions, are there any more questions? Anything to discuss about? Good. If there are no more questions, we are coming to the conclusion of this event. And I would like to extend my thanks to all the faculty and all the delegates who have attended the meeting and who are going to watch in OrthoTV and as well as YouTube channel. Thank you very much for watching our program. And thank you, Dr. Ali Maqdes, for joining us as a guest speaker and giving a fantastic speech you gave. Thank you very much. Thank you, Jyoti, and thank you, Akil, for contributing your evidence talks. Thank you very much. And I thank Sun Pharma team as well as OrthoTV team. Thank you, one and all. Thank you, Prajwal. Thank you, everyone.
Thank you, sir. Thank you, sir.
Thank you.
Thank you. We are coming to the end. Ali, keep in touch.
Thank you very much, sir. Thank you.
Yeah.
It was very nice. I enjoyed it.
Yes.
Take care and keep safe, please.
Thank you. Yeah.